Sometimes I look at doctor's orders and I kind of scratch my head and I think, what the heck were they thinking or what was going through their mind? So, do I always follow the doctor's orders? Let me explain. But before I do that, I just want to introduce myself. My name is Austin Marks. I am currently a respiratory therapist. I've been in RT for about 2.5, almost 3 years now. I currently make videos all about respiratory therapy on my YouTube channel. I do have some other videos talking about a few other things. If you like what you see, make sure you like and subscribe. It really helps me out a lot. I am also the Facebook admin of a Facebook group called the RT Club, and on this Facebook group we talk everything respiratory therapy. So in this Facebook group it has respiratory therapists, respiratory therapy students, and anyone looking to aspire respiratory therapy. So if you want to be part of this community, make sure you head over there and join. So going back to, do I always follow the doctor's orders? Because sometimes I look at them and think, they have no idea what they're doing. So I do want to say that 99% of the time I do follow the doctor's orders, or I will collaborate with them and come up with a game plan. So let me kind of explain here. So at the facility that I currently work at, we have something known as protocols. So they are called patient-driven protocols, which allows the respiratory therapist to go in and evaluate the patient. It allows me to listen to breath sounds, look at the history of the patient, the chest x-ray, and I kind of gather all this information and I decide what the therapy is going to be for the patient. So a lot of times ER physicians or admitting physicians or hospitalists will kind of admit these patients from the ER and they will go ahead and just select the medication, but they won't select the frequency. So for example, I'll get albuterol every 2 hours and every 4 hours, and I'm like, that's probably not good for the patient. But the physician also puts in a PDP or a patient-driven protocol, which allows me to go up, evaluate this patient, change all the doctor's orders, and put in what I think is necessary. So let's say I go up and I evaluate this patient, and I say, oh, they don't need any breathing medications at all. I may make it PRN or as needed, or I may go ahead and just do away with the breathing treatment because I asked them a bunch of questions such as, do you ever smoke? Do you take any breathing medications, any breathing problems? Along with all that other information I told you earlier. And they say, no, I don't do any of that stuff. So why do they need breathing medications or any kind of therapy if they're here for something totally unrelated to respiratory? And I don't think they need it. They don't think they need it. I'll call the doctor sometimes and I'll say, hey, do you think they need this? A lot of times the doctor will say, oh no, I just put it in there, so you go up and evaluate them. I don't always call the doctor because sometimes I know personally that the patient doesn't need this. This is why my hospital has protocols, so I can go up and evaluate the patient because I'm competent in my skills. The physician knows that I'm competent, and we basically go off of that. Now at my facility, this happens a lot for patients who are being admitted to the hospital as well as patients who basically go get surgery done. So sometimes a patient will come out of surgery, the physician will order a boatload of stuff such as like EasyPap, ISB, breathing treatments around the clock. They'll do a CPT or chest physiotherapy, as well as an oscillating vest, which kind of is a vest that you just wrap around the patient's chest, shakes them up for about 15 minutes. This kind of helps out bring up any mucus in case the patient can't really call for anything. Just a whole bunch of stuff the patient doesn't need, because even if the patient is 25 years old, such as myself, and they had appendicitis and got their appendix removed, they're going to be in the hospital for like a day. They don't need all that stuff. If they're a young, healthy individual, they'll be just fine. However, the doctor still sometimes orders all that stuff. I have to go in, I still evaluate the patient, I talk to them, figure out all this stuff, and I'll most likely do away with all that stuff except for like deep breathing exercises, or if they have asthma or some kind of other respiratory issue and they take breathing treatments at home as needed, I'll leave that in. That way, if they want a breathing treatment, they can call me up and say, hey Austin, I'm having a little difficulty breathing, can you come give me a treatment? And I'll do that, I'll make that happen. Another great thing about my hospital or my facility is that we have protocols for the ventilators as well. So a lot of times in the mornings is when we'll draw ABGs, and I'll look at the ABG, I'll look at the vent settings or the life support, and I'll say, okay, I want to get my patient a little bit more correct with all their values, so I'm going to adjust this. So I may adjust the rate, the tidal volume, the PEEP, whatever. The FiO2, I can go ahead and adjust that whenever. So I will go ahead and I'm allowed to change whatever. If I want to change the mode, I can, as long as it's not something extremes, like I'm going into APRV. I can do all that myself. So with vent settings, we want to make sure that everything is accurate in the computer as well as what's going on the ventilator. So I want to go in under the physician's name and I want to sign the vent settings. That way everything is accurate, everything matches up, because if it doesn't match up, that's a huge no-no. Same with medications that we're giving to the patients, everything needs to match up. You want to give the patient what they're supposed to get, what the doctor says they're supposed to get. And then once again, a lot of times when I do make these changes, I'll call the physician, provider, whoever is on, and I'll say, hey, I made this change. Sometimes when we call them, we have a secure text, that way nobody can see it except for that physician. It's highly classified or whatever, so nobody can see it. It's just an extra protocol the hospital takes to protect the patient, but sometimes I'll even just text them and then they'll reply an hour or so later, because sometimes they're busy doing stuff or they're sterile, they can't touch their phone, whatever, and they'll get back to me and say, oh yeah, that's awesome, no problem. Once again, it's because they know I'm confident in my skills and they trust me. So all in all, do I follow the doctor's orders? Yes, 99% of the time. It's like I said, a lot of times they give you that protocol to go up and do it yourselves. They just put in nonsense sometimes, just because they say, oh, I want this person to get this med or whatever, like I told you earlier, and they know that I'm going to go up and I'm going to change it. So that's the only times I don't follow physician's orders, is when I have the ability to go in and change it, because I'll look at it and scratch my head and I'll say, that doesn't make any sense whatsoever. I apologize, it was my phone. Go Penn State. Well, anyway, if you have any questions about protocols, following physician's orders, whatever, leave it in the comments below. One thing I do want to add is it is important to always look at the orders and make sure the physician is putting in the correct things, that you agree with it, because if something's in there that you don't agree with and you don't think you should really do it, you probably shouldn't do it. Probably call the physician and say, hey, are you sure you want to do this? Because they're humans too, they make mistakes sometimes, so that's why you always want to double check yourself. Well, anyway, hope you enjoyed this video. If you have any questions, make sure you leave in the comments below, and I'll see you in the next one.